Hi, my name is Brittany Kuka. I am a licensed professional counselor here in Washburn, Wisconsin. I'm here tonight with the Auxilia Initiative. We are a nonprofit organization that focuses on early intervention and prevention with both first responders and community members. Today, we're going to talk about suicide prevention and what that looks like in the community. So our agenda today, we're going to talk about prevalence. How many people is this affecting? What does that look like here and across the globe? Risk factors, protective factors, prevention, which is kind of what we're here to talk about. A screening tool called the CSSRS, and community resources. So to start with, I just want to say that if you're here watching this, you may have had personal experience with suicide. A family member or a friend may have completed suicide or may struggle with suicidal thoughts, or maybe you yourself may struggle with suicidal thoughts. You're going to learn new things tonight that maybe you didn't know before. And when we know better, we can do better. So please be gentle with yourself if you learn something new. This is a heavy topic, so please take care of yourself during and after this presentation. You probably didn't log on here just for fun today. So just remember that during and after this presentation, it is heavy and it can take a toll. So just take care of yourself. Take a break if you need to. I'm going to be upfront and say that I stole this tagline. I am giving credit to the Department of Homeland Security, but we're going to repurpose this saying. If you see something, say something. Most people are pretty familiar with this. If you've been in an airport, you have probably seen this plastered all over the walls. If you see something, say something. That is going to be our motto today. It's going to be our tagline that I want you to take with you. Suicide prevention is about noticing when someone might be struggling and then doing something about it, saying something about it. And so we're going to repurpose this. If you see something, say something. I also think it's appropriate to repurpose this, not saying that we can't still use this at the airport if you see some unclaimed baggage, but suicide is a much bigger threat than terrorism. Suicide claims 740,000 people each year, and terrorism claims between 3,000 and 8,000 lives each year across the globe. So suicide is definitely a larger threat to us than terrorism is, and not to minimize the threat that terrorism is to us in this country, but suicide is taking a lot more lives. And so we want to be vigilant. We want to notice when someone is struggling, and we want to speak up. So where is this happening? Who is this happening to? How often is this happening? These statistics can be kind of a bummer, but I'm going to share them so that you know what this looks like. Suicide kills 4 times as many military members than those killed in action. This is over the last 20 years. So we know that post 9/11, more military members were killed by suicide than in war. More soldiers were killed by suicide than in combat, and this averages about 18 veterans per day. Suicide kills more firefighters than fire. First responders are at a very increased risk of suicide. Suicide kills more police than crime. Suicide kills more Americans than car crashes. And suicide kills more people across the world than natural disasters, war, and homicide. For young people, this is a particularly significant threat. In a typical classroom, 3 students likely attempted suicide in the previous year. 22% of high schoolers seriously considered suicide the prior year. And the gender differences here is that 6% of boys and 13% of girls in high school attempted suicide the prior year. So not only are students thinking about it, but they're attempting it at pretty significant rates. Suicide kills more teenage girls across the globe than anything else. And for students that are part of the LGBT population, they're at significantly higher risk. 48% of LGBT high schoolers seriously considered suicide in the prior year, and 18% of boys and 24% of girls attempted in the last year. That is significantly higher than the general population of high schoolers. As a note here, we do know that for teenagers and for LGBT population in general, for LGBT youth in general, just having one stable adult who they can trust and who they feel has their back is a huge protective factor for them. So while they are at increased risk of suicide, if you're an adult watching this and you have someone in your life who might be at risk, you can be a safe, stable person for them. So there are some higher rates of prevalence in certain populations. People with chronic medical illness are at a higher risk than others. At least 10% of suicide deaths are linked to chronic illnesses. Particularly young people with chronic illness are 3 times more likely to attempt suicide. People with chronic illness and pain, things like fibromyalgia, chronic back pain, and things like that are at much higher risk. Substance abuse, people who have substance abuse issues and dependency are also at a higher risk. Opiates are present in 20% of suicide deaths, and acute alcohol intoxication is present in 30 to 40% of attempts. So not only is having a history of addiction going to put people at risk, but it's also part of how people are attempting suicide. Up to 40% of people presenting for substance use treatment report a history of suicide attempt. So these two things are really happening together quite a lot of the time. It's probably no surprise that depression is something that correlates with suicide risk. 50% of people who die by suicide have an untreated mental health disorder, most often depression. And then another thing that correlates with high rates of suicide is undertreatment. Over 80% of adolescents and college students who died by suicide received no consistent treatment prior to their death. So we can sort of assume that people receiving adequate and timely treatment is going to really benefit them and reduce suicide rates. So rural areas have the highest rates of suicide. Rural areas have communities that are far apart, less consistent access to medical care, providers are far away and usually overburdened, and there's high rates of gun ownership. In our own community, Bayfield County has the highest rate of suicide in the state per capita. And we are a very under-resourced community. There are not enough mental health providers to meet the need. There are long wait lists, and there's just not enough services available for the people who need them. Access to firearms is also a risk factor. Over 50% of US suicides are by firearm. 10 children every week kill themselves with a parent's gun. And firearm security is one of the most important things you can do. I'm just going to say right now, this presentation is not about guns being bad. I am a gun owner. My son got his first deer this year, which was very exciting. He was so excited to share his jerky with all of his friends. But having your gun stored securely and being a responsible gun owner is the most important thing that you can do to prevent suicide. We will talk more about this later on, but having secure guns is the biggest thing you can do to prevent suicide. There are some vulnerable groups as well. So there are increased suicide rates among Black youth, people living in impoverished communities, people with food insecurity, people with housing instability, and people who lose access to health insurance. I described earlier that Bayfield County has the highest rate per capita in the state of Wisconsin. And we have some of these vulnerable groups in our community. We do have high rates of poverty and a significant rate of housing instability as well. Okay, so some concrete risk factors here. This is from the research that has been compiled from Columbia University, which is kind of the leader in suicide prevention. Your history is a big risk factor. If you have a history of abuse, adverse childhood experiences, prior suicide-related behavior, so have you attempted suicide? Have you had suicidal thoughts and ideation before? Do you have mental health struggles? Have you been diagnosed with a mental health disorder in the past? Have you had treatment in the past year? Have you attempted suicide in the past? And do you struggle with substance abuse? Those history things will increase your risk of suicide. Those are risk factors. A disrupted social network is a risk factor. Are you in transition? Are you in between schools, in between jobs, in between friend groups? Have you just moved somewhere? That can be a risk factor. Do you have an unstable or maybe no peer or social network? Do you have a job? Those are things that can be risk factors. Then there's judgment factors. How is your judgment? Do you make good decisions? Are you able to decide if something is going to be a benefit to you or if it's going to cause you harm in the long term? How's your sleep? Have you had a recent event that might cause you to react poorly to something? Are you under the influence of alcohol, which can impair your judgment? Then again, access to lethal means. Do you have access to firearms or do you have unsecure firearms? Health issues, pain, either physical or emotional, increased health problems, which we talked about before with chronic conditions, or a decline in your physical ability. For some people, this might be a lack of mobility or independence. And then there are some other contributory risk factors like impulsivity. Again, a recent event that might have triggered something like feelings of shame or guilt. A loss of status, meaning maybe you got fired from your job or you had a demotion. And then feelings of rejection or abandonment. Maybe you had a partner break up with you or something didn't work out the way you wanted it to. Feelings of hopelessness or helplessness, maybe being isolated, and then increased alcohol or drug use. The good news is when there's risk factors, there's also protective factors. So we want the protective factors to outweigh and balance out the risk factors. And so just because somebody has many risk factors or several risk factors does not mean they are bound to attempt suicide. It just means that there are some things in their history or in their current presentation that say they might be more at risk of attempting suicide. But we want to look at their protective factors too. What's going right? What is a strength for this person? And so here are some of the protective factors that you might be looking at. Again, history. What's going well for this person from their past? Do they have a history of employment? Do they have a strong sense of cultural identity? And I would even add that some of those things that were on the risk factors for history, is there a lack of those things? Do they not have some of those things that were risk factors in their history from before? Social network. Do they have a sense of belonging? Do they have a sense of sharing and feeling connected to others, feeling connected to their school, their community? Do they do things with their friends? Do they, if this is a teenager, are they part of school clubs or sports? If this is an adult, do they go to church? Do they have a hangout with their friends once a week or every other week? How do they stay connected to people? Do they have support from their friends and family? Who do they go to when things are going badly, when things aren't going the way they want them to? And then judgment factors again. Can this person effectively cope with hard things? Can they solve problems well? Do they have a reason for living? Sometimes when someone is having difficulty, they might be feeling depressed or maybe even having suicidal thoughts. And we say, what's one reason for living? They can say, my cats, my dogs, my kids. Do they have a reason to live? And if so, that's a protective factor. It's something keeping them here. Do they have cultural, religious, or moral objections to suicide? That's actually a strength. If someone's religion is telling them or someone's culture is telling them that completing suicide is immoral or wrong, despite what you may feel about that, that's actually something that might be keeping them here and is a protective factor. And again, access to lethal means. Do they have a reduced access to lethal means? Is there a lock on the safe? Is there maybe a bigger barrier than that? Does the gun live at someone else's home? Do they not have a gun? Does this teenager not have access to their medication because their parent provides the medication every day? What does that access to lethal means look like? And then health. Do they have access to physical and mental health care? Can they go to the doctor when they need to? Are they able to make an appointment and not worry about the cost? Do they have a therapist? And then there are a couple of other things, which is hope. Do they have hope for the future? And help-seeking behavior. When they notice that things are getting difficult, do they seek help? So these are all protective factors. And just like with risk factors, we're not going to jump to a conclusion and say this person is going to do something. These are just things that we are looking for to see how does this balance out with their risk factors. So static and dynamic risk and protective factors. This is how we're going to look at that balance of these things and say, what's happening right now? Because some of these things change and some of them don't. So static factors are things that don't change. They're going to be the same regardless of when you talk to someone. So static risk factors would be like a history of suicide attempts, history of childhood abuse, their age, race, gender, historical diagnoses. Those are not going to change. Protective factors that aren't going to change are things like their historical ability to adjust to adversity, good emotional regulation skills, strong religious beliefs about suicide. Those are things that aren't going to change regardless of when you talk to this person. Their history is their history, right? But there are things that might change. Dynamic factors change, they fluctuate, and they can change a person's risk level. So some risk factors that might change would be current thoughts of suicide. Maybe somebody has never attempted before and they didn't used to have thoughts of suicide, but they're having thoughts now. Current symptoms, substance use. They were sober yesterday, but they aren't today. That's going to change their risk. Recent stressors like a breakup or a job loss, that will change their risk. And access to lethal means, that will also change their risk. But there's also dynamic protective factors. like a recent positive relationship. Sometimes I will hear people say, I just got together with this person, or maybe I made a new friend, or I got this new job. And that has changed their outlook and their hope for the future. Current therapy, reduced access to lethal means. I gave my gun to my brother and he put it in his safe. Now, that's a huge dynamic protective factor that has shifted. And then an improved environment. I moved out of my mom's house and she's not yelling at me anymore. Those are things that can change, that can really reduce your risk. So I want to share a story. I'm going to talk about Anna. Anna is not her real name, but that's what I'm going to call her today. And this is just an example of how static and dynamic risk and protective factors can look like in real life. So I worked in residential treatment when I lived in Alaska, and I was working with girls 13 to 18 years old. And Anna was about 15, and she was in residential treatment because she was a victim of potential child trafficking and sexual abuse by a young 20-year-old military member. And there was an ongoing court case, an ongoing investigation, and she had already been through quite a bit of treatment. And by the time she came to the treatment center that I worked at, she was pretty stable. And I worked with her for a few months, and she was doing really well. She was going to public school, which is how our treatment center worked. She was getting along really well with the other girls, and she was doing well in therapy. All of her protective factors were really outweighing her risk factors. She had a previous history of suicide attempts. Over a year ago, she had been in treatment, doing well, and had not had suicide attempts since then. But one night I was on call and I got a phone call that said she's just attempted suicide. And I did not know what had changed because I had just seen Anna that day and I had had therapy with her and everything had been fine. And I kept going over the whole ride to the treatment center. I was thinking, what did I miss? What did I miss? What did I miss? And it turns out nothing. She really was okay at 4 o'clock in the afternoon. She was not suicidal. And all of those static protective factors had been there at 4 o'clock in the afternoon. But what happened is a dynamic risk factor, something that changes, had happened in the evening. And she had snuck a phone call. She had quickly changed the number when a staff member wasn't looking. And she talked to the person who had perpetrated against her. And we still don't know what that phone call looked like. We don't know what she said, but she immediately went to her room and attempted suicide. And that is a dynamic risk factor that can happen like that. And I will talk a little bit more about this later, but most people who attempt suicide do so very quickly after deciding that they are going to do it. Most people do not make a plan and plan for days and days and days. For most people, there is a dynamic risk factor, something that changes quite suddenly that prompts them to attempt suicide. And so being aware of people's current histories, their, what's happening in their life right now, and also knowing what might sort of tip this person over the edge. What might that dynamic risk factor be that would cause this person to go from I'm okay to I'm not okay. So now we're going to talk about prevention. What do we do, right? You know now that this is a big problem. There are too many people that we lose to suicide every year. You know what the risk factors are, you know what the protective factors are. So, what do we do about it? The two biggest things is we want to support people in their struggle and we want to make it harder to attempt suicide. Supporting people in their struggle looks like economic supports. We know that when people are struggling with poverty, that's a risk factor. We want to provide access and delivery of care. We know that when people don't have health care or mental health care, they're going to struggle more. We want to provide protective environments, connectedness, help people with coping and problem solving, and identify and support those at risk. A lot of these are things that you just might not be able to provide. Some of these are things that are out of your control, but we can talk about some of these and how you can do that. So if you are able to provide some of these things in a real way, you absolutely can. If you can support somebody financially who is struggling, you can do that. If you can help somebody access healthcare, you can do that. But more meaningful and more realistic probably is to provide a feeling of connectedness. Check in with people. Find a way to consistently be there to support people when they're struggling with their mental health. For people who are struggling with coping and problem solving, help them get help. We'll talk about community resources at the end and connect them with resources that can help them with coping and problem solving skills. And then identify and support those at risk. That's what we're going to talk about with the screening tool, the CSSRS. So in making it harder to attempt suicide, this is, I know I talked about guns earlier, this is the most important thing we can do. Again, because so many people who attempt suicide do so quickly after having the thought, we want to create a barrier between the moment they think about completing suicide and when they actually try. Oftentimes, people just need a little bit of time for some alternative coping to kick in. And we want to give them the space to do that where they don't have access to lethal means. We want to make it harder for them to attempt suicide so that in an hour, they are still here to think about it twice. So this looks like safe storage of firearms and medication. In my own home, we have a safe. The safe has a lock. The key is in a medication lockbox that has a code. That lockbox is in a different room, and the ammunition is stored somewhere else. This can look lots of different ways, but I will say there is not a way that is too safe. Medication, if it has the potential to be lethal, should be stored in a medication lockbox, particularly if you have kids and teens. Eliminate glorification of suicide and change how we talk about suicide. So there are a lot of movies, TV shows, internet media that do glorify suicide. And some of it may be even disguised as people who end their lives in different ways, not necessarily because they're depressed or because they have a mental health disorder, but maybe in other ways because they are sacrificing themselves for a cause or because they do this in an act of heroism. And so being able to eliminate the glorification of suicide and then to also talk about suicide in a way that is real. to talk about suicide as the result of struggle and not as something that is either one extreme or the other, either this glorification or on some ends, sin. We want to normalize help seeking. People struggle. People struggle with daily life. And we don't have to have a mental health disorder to seek help. So we want to make the way that we talk about seeking mental health, we want that to change. We want to reduce the stigma, and that's something that we can help with too. And then decrease barriers to care. If you know somebody, if you are the person trying to get somebody help, eliminate as many barriers to care as you can. Okay, so this is an image to kind of explain protective factors and risk factors. You can see on the left-hand side there the protective factors like access to health and mental health care, employment, family and peer support, help seeking, good problem solving, emotional regulation skills, hope, belongingness, sharing, right? They're all stacked up there. Nice, beautiful protective factors. And then on the right-hand side, you have the risk factors like impulsivity, family history, substance abuse, trauma, mental health diagnosis, access to lethal means. And without those bright pink things on the top, there's actually more protective factors than there are risk factors. But then we have triggers. These are those current things that start to come in, those dynamic risk factors, relationship breakdown, legal issues, financial issues, disciplinary issues. And you can see that it starts to tip, right? Now it's not so balanced. And then there's another thing that gets added on here that we haven't talked about yet, which is perception. And this says, how am I viewing my situation? Am I viewing my situation and saying, you know what, I know my relationship is, not doing well, but I'm going to get back up and try again? Or am I saying the world would be better off without me? No one cares about me. And when we take all of this together, and now the perception, the view that I have of my situation and myself, now we're leaning this way, and the balance is no longer tipping towards protective factors, it's tipping towards risk. And this person that's displayed here is at more risk of attempting suicide. All right, so we're going to talk about some myths because there are some myths when it comes to suicide and just talking about it. The first one is that asking a depressed person about suicide will make them want to do it. That is not true. Risk is not asking when someone is in need. We are not going to make someone think about suicide more. If they are thinking about suicide, they're already thinking about suicide, right? And having that conversation is actually going to feel relieving to them because now they can talk about it. And if somebody's not thinking about suicide, if they are not thinking about killing themselves, you asking, are you thinking about killing yourself? That is not going to make them think, well, you know what? I think that's a good idea. That's not how it works. The risk is in not asking. If they're going to do it, they won't tell you. That's not really true either. Most people, not all, but most who are having suicidal thoughts will tell when they're asked, even if they wouldn't have volunteered the information on their own. When you ask directly, most people will tell you that they are having these thoughts because it is relieving to them. They want to tell someone because it is scary to have these thoughts. 80% of people actually give hints and warnings to friends and family. Ambivalence, meaning I'm not sure if I want to do this, is present in 95% of people. They haven't made their minds up yet. 95% of people. That is almost all, right? 95% of people haven't made their minds up yet. And so asking, are you having thoughts of hurting or killing yourself? Are you having thoughts of suicide? Asking really is going to save someone's life because they have not decided yet. The next myth, if they're really suicidal, they're not going to, or they're going to do it eventually, no matter what you do. Also not true. More than 90% of people who attempt suicide and survive do not go on to die by suicide. Most people are suicidal for only a short amount of time. And again, helping someone through a suicidal crisis can be life-saving. So most people are not going to be suicidal, attempt, and then continue until they complete the job. This is just not what the research shows. Most people do regret the attempt later, are happy that they survived, and do not go on to die by suicide. Okay, so we're going to come back to this because I want you to remember, if you see something, say something. If you see something that feels off, if you see someone is looking down, if they are not acting themselves, if they are giving away items, if they have been talking about maybe not wanting to be here anymore, if you are seeing these signs, say something. We're going to talk about what that looks like. So, more means safety. So, we've already talked about reducing access to firearms and how this is so important. But I want to share what that actually looks like and that there is research behind reducing access. So, mean safety is reducing a suicidal person's access to highly lethal means. There is strong evidence of this as a suicide prevention strategy. These are just some examples. There are more research studies that have been done on this. These are just a few. These are communities that reduced access to lethal means. In 1958, in England, they replaced coal gas with natural gas, and suicide rates via carbon monoxide poisoning reduced by 1/3. It just wasn't available anymore. They did not have that option. In 1998, again in England, individual blister pack Tylenol. So instead of selling Tylenol in a bottle, they started selling Tylenol in blister packs, which anybody who has dealt with that knows it's very challenging to get medicine out of those blister packs. That reduced suicide rates via overdose by 44%. Huge number. It is that barrier, it's the gap, it's the buffer that people need between I think I want to kill myself and I'm going to take the action to kill myself. And then, oh, wait, I don't think I want to do this. It provided enough buffer for people to reduce overdose rates by 44%. It's an incredible study. And then in Israel in 2006, the Israeli military restricted gun access for off-duty soldiers. They said, if you're on duty, you can have your gun, but when you're off duty, you cannot have your weapon. And the military suicide rate was reduced by 40%. Reducing lethal means is incredibly effective. So again, the take home is if we can reduce access to lethal means, we can provide this buffer and we give people a chance to have that space, that gap, that breath to hopefully come back to that moment of, wait a minute, I don't think I want to do this. So why does means safety work? So number one, lethality matters. What kind of method are you using to attempt suicide? It matters. So here's a little chart that shows the method and then the lethality. How lethal was this, right? How many people were actually successful in completing suicide? How deadly was this? Firearms, the lethality is 85%. Suffocation is 69%. A fall, right? A fall from a window, a fall from a bridge or a building, 31%. Poisoning and overdose is only 2%, and cuts is 1%. So reducing access to those lethal means is very important, because if you don't have access to the things at the top of the list, you have a much better chance of surviving. Or some people, if they don't have access to a firearm, will not attempt the other options. Number two, most attempts are not planned. 25 to 40% make the attempt within 5 minutes of making the decision. Within 5 minutes, they are attempting suicide. It's very impulsive for 25 to 40% of people. 70% make the attempt within an hour of making the decision. It's a little bit longer, but it's still not a lot of time. And so again, that buffer that we want to give people is, we just want to give them an hour. We want to make it hard for you for an hour. And so when you think about reducing access to lethal means, we want to make your life hard for an hour and not give you access for that time. Most attempts happen at home. 75% of people who die by suicide die at home. And for ages 5 to 11, and yes, kids do attempt suicide and complete suicide, it's 95%. We want to protect children, and we want to protect them in their home, which is where they are most likely to complete suicide. And we can make a difference in the community by normalizing asking the questions, meeting people in the community, like not waiting until they come to the clinic or the therapy room, and removing access to lethal means. We can help. If somebody is coming to my office, if they're coming to the therapy room, we're going to be able to have this conversation, and we're going to have the conversation. But oftentimes, the people who need to have the conversation, they might not be in my office yet. They might not be in the other therapists' offices yet. And because we live in a rural area and there are not enough services available, some people aren't getting the help that they need. And we want to make help available everywhere. And we want our community members to be able to notice when something isn't okay, and to identify people who are at risk and be able to ask the hard questions. Okay, so now we're going to talk about this CSSRS. This is kind of the whole thing that that we're going to be teaching you. This is the prevention part of this. So the Columbia Suicide Severity Rating Scale is a screening tool. It's endorsed, recommended, adopted, all of these things by these different international agencies. There are thousands of studies on this. It is highly evidence-based. It is very well supported. It's in 148 different languages. There's no training required to use it. It is made for your everyday person. There are different versions available online. There are versions for police officers. There are versions for teachers, for community members, for parents, for coaches. There's versions that we use in the therapy room. But the great thing about this tool is that you don't have to be trained as a professional to use it. This is a public health model. It meets people where they live and work. The idea is that all community members are gatekeepers. As a community member, you see people in their everyday life, living their, going about their day, right? Not in the doctor's office, not in the therapy room. And that is where the real opportunity to intervene is, and where we can really catch people. Screening also helps normalize talking about suicide. We don't want to wait until people are getting their yearly physicals to say, hey, are you having these thoughts? We want to be able to just talk about it and say what's going on. And that's what the CSSRS does. So this is the CSSRS. It looks a little bit complicated, but I promise it's not. So there are just these 6 questions, and you might not even have to ask all of them. So we're just going to walk through this. So the first question is, in the past month, have you wished you were dead or wished you could go to sleep and not wake up? If they answer yes to that, you're going to go to number 2. Either way, yes or no, you're going to go to number 2. Number 2 is, have you actually had any thoughts of killing yourself? The reason we want to know, have you actually had any thoughts of killing yourself, is because sometimes people just have thoughts of wishing they were dead or would not wake up. And that's very different than actually having thoughts of killing yourself, which is an action. And so if number 2, if the answer is yes, then we're going to go down to numbers 3, 4, 5, and 6. If they say no to number 2, you're going to skip those questions and go straight to number 6. So we're just going to assume, let's say someone said yes to number 2. Then number 3 is, have you thought about how you might do this? What that means is, have you made a plan for this, right? Have you thought about this, right? When it says, have you thought about how you might do this? Someone might answer well, I thought I have some pills at home and I thought that might be easy. Or I have a gun and I thought I might just walk off into the woods. Those are the kinds of questions or the kinds of answers that you might receive from here. Number 4, have you had these thoughts and had some intention of acting on them? What that question is asking is, have you thought about actually doing this? Have you thought about actually acting on this plan? Number 5, have you started to work out or worked out the details of how to kill yourself? Did you intend to carry out this plan? Have you put some things into place, right? Have you thought about, well, I know my mom isn't home after school, and so I think I would probably do it then. Or, well, I don't know exactly what it would look like, but I know that I need to get into the safe, right? If there are some details there, then that's a yes. Or if they say, well, I don't know, it's kind of more just a thought, then that's probably a no. No, I don't intend to carry this out. I don't think I could ever do it. Then that's a no, right? And then number 6, have you done anything, started to do anything, or prepared to do anything to end your life? So they give some examples here, like, have you collected pills, obtained a gun, given away valuables, or written a letter, held a gun to your head but changed your mind, right? And then depending on whether this is a yes or a no, if yes, was this within the past 3 months? So once you've asked these questions, then you go to the bottom and it says, if yes to 2 or 3, a mental health referral may be helpful. And so we'll talk about that in a minute. Or you can use the QR codes for the app to find referrals. There's a QR code in some subsequent slides. If the answer to 4, 5, or 6 is yes, get immediate evaluation. Call or text 988 or reach out to a helping resource. If you are helping someone else, stay with them until they can be evaluated. So what does this look like in our community? So If yes to 2 or 3, a mental health referral may be helpful. So, yes to 2 or 3 means they've had some thoughts of killing themselves. They've thought of how they might do this, but they haven't made any plans. They don't intend on doing this. So, we want to get them some help, but it's not a crisis. And so, there, in some following slides here, there are going to be something called community resources and then outpatient mental health referrals. And you can scan those QR codes or save them for later. But you want to get this person hooked up with some therapy, right? You want to get them hooked up with counseling, some mental health help, so that they can figure out what's going on and also make a plan for any future thoughts that they might have. Just because someone is not having a plan right now and they're not high risk right now doesn't mean they might not be in the future if something doesn't change. So we want to get them hooked up with some help, and you can provide them with some resources. Now, if the answer to 4, 5, or 6 is yes, meaning they have had some intention of acting on them, they maybe have started making some plans, or they have some details of how this might work out, then we want to get them evaluated. And what that looks like in our community is we want to get them to the ER. In Washburn, Bayfield, Ashland, in this area, that looks like going to the emergency room. Here, that's Tamarack. In other communities, that would be just going to the emergency room and saying, hey, let's get evaluated for your suicide risk. There are some other crisis resources that I will talk about in a minute, but that is usually going to be the resource that you're probably going to want to use. The other thing on the bottom of here that I want to talk about is that if you are helping, you want to stay with them until they can be evaluated. We don't want to leave someone and say, hey, you should get checked out for this. See you later, right? We want to stay with them. That might mean riding with them to the emergency room or to the crisis bed. But we really want to encourage them to get this done. And if they are resistant to that, there are some options that we have for that as well. So let's talk about how to deliver it. I'll talk about some crisis resources in a minute. So we want to be present with the person. Try not to be distracted. Don't be on your phone. Don't be thinking about these other things. Just really be present with them. Have positive body language, make eye contact, be approachable. It helps to stay calm. This can feel scary for people who don't deal with this every day. But remembering that they are not trying to end their life right in front of you. We're just having a conversation, right? And that can be maybe helpful to remind yourself of, is that we're just talking about this. And the more we talk about it, the less scary this has to be. Being attentive and responsive, nodding your head and letting them know that you're listening to them. You really want to understand what's happening here. Having a steady and clear voice, listen carefully and don't judge, right? The reasons they have for feeling the way that they do may not feel valid to you. They might not make sense to you, but to that person, this is a crisis. This might feel like the end of the world, and it might not really add up in your mind. But for this person right now, this is feeling catastrophic. And so not judging what's happening for them. Paraphrase and reflect back important details. If somebody is telling you that they are feeling suicidal because their girlfriend broke up with them and they just can't imagine living without her, you can reflect that back and say, wow, it just sounds like, you loved your girlfriend so much that you just can't imagine living without her. And it's feeling really hard right now. Just say it back and see if you got it right. See if you're understanding them correctly. Ask the questions directly. I know I gave some different wording as I was explaining the questions, but ask the questions directly and use the wording on the screening tool. Just say them directly to the person. We don't want to beat around the bush and say, oh, are you having dark thoughts? Or, are you feeling like not yourself? Nope. We want to say exactly what is on that screening tool. Take time to listen to their story. Sometimes, oftentimes, people will have suicidal thoughts. And by just listening to what's happening for them, by the time they have talked about what's going on, they may still have suicidal thoughts, but they don't want to kill themselves anymore. Let them know that you're worried about them, right? This isn't, it's not a punishment. I'm not asking because I think something's wrong with you or because I'm trying to punish you. I'm worried, right? I'm worried about you and I'd like you to come with me to get help, right? Ask them to come with you to get help. Be caring and patient. And then this is the important part is don't take no for an answer if the person is high risk. On the screening tool, you'll notice that there were things that said high risk. And if you answered yes to those questions, that's high risk. This is very uncomfortable, but if someone is high risk and they're saying, no, I don't want to go for an evaluation, I don't want to go see somebody, there are options that we have as people who care about that person. And one of those options is to call for a welfare check and say, hey, I have this person with me. They are suicidal. And I think that they need to get some help. And so we can call 911, we can call dispatch, depending on the level of emergency that you think it is. And then you can get some help. And the people who come to help you can determine whether or not that person might need to be escorted to the emergency room. Again, I know this can feel very uncomfortable, but at the end of the day, we want people to be safe. And if somebody is high risk, meaning they are having thoughts of suicide, they have a plan, they are thinking of how they can carry out this plan, right? And they might even be intending on doing this. That is a person who is high risk, and we want to get that person help right away. And then avoid minimizing feelings. Don't try to talk them out of it, and don't try to give advice. What we want to do for this person at this point in time is, administer this tool, and then if they are in need of help, we want to get them help. Okay, so again, if you see something, say something. And the say something at this point is the CSSRS tool, right? This is what we're saying. I'm worried about you. I'm going to ask you these questions. And depending on the answers, it might be okay. Like, thanks for talking. Or it might be, I'm going to get you some resources and I think you should call and maybe try to talk to somebody. Or it might be, I'm really worried about you and it seems like you're having these thoughts of hurting or killing yourself. And I think we should go to the emergency room and talk to someone. Or it might be, I think we should go to the emergency room. And since you don't want to go, I think I'm going to call and get some backup. Okay, so here is the QR code for the Columbia Protocol. The people at, this is called the Lighthouse Project. They are amazing. This is through Columbia University. They're the people who created the Columbia Screener, but they also have amazing resources. If you want to scan the app, they have compiled resources for communities. You can kind of scan and look at what are the crisis resources for my community. But they also have a ton of other versions of the Columbia Screener. We have, I don't have it right here with me, but we have these pocket-sized business card versions of the screener. And we had them available for the in-person presentation. And if anybody is interested in having a pocket-sized version of this screener, please just contact me and I can arrange for you to pick one up. They are made to just fit in your wallet so that if you encounter someone that you want to ask these questions to, you can just pull it out and look at it. So if you would like that, you can just email me and I can make sure that you get that. Okay. So here are the crisis resources in our community. You can call 988. This is obviously not unique to our community. You can text Hope Line to 741-741. There is a NAMI warm line. A warm line is different than a crisis line. You do not need to be experiencing suicidal thoughts to call the warm line. If you're just feeling lonely, you feel like I need somebody to talk to, I'm just having a rough time, you can call that warm line and they will be happy to talk to you. And that's the thing that's great about the warm line, is because sometimes people are very hesitant to call the crisis line if they aren't quite in crisis enough. And so the warm line is great and you should utilize it or encourage other people to utilize it. Go to the emergency room. If you don't know what else to do, go to the emergency room. We also have the Northland Counseling Crisis Bed. The number is right there. So if you think that that might be a better fit for you or for the other person, they do crisis screenings and sometimes have availability depending on what their capacity is like. They sometimes have availability there instead of at the behavioral health unit through Tamarack, which is our next resource, Tamarack Health Behavioral Health Unit. In order to be admitted there, someone first has to go to the emergency room to get an assessment. And then I know I already talked about this, but you can call 911 and ask for a welfare check or an escort to the ER if somebody is refusing to go to the emergency room. This is, I would say, kind of like a last resort, but if someone is not cooperating with going to the emergency room on their own, we want to get them there. If they are high risk, we want to get them to the emergency room. Okay, so here are the QR codes for the outpatient mental health resources and the community resources. The community resources also has some therapy services, psychiatry, social services, things like that. Outpatient mental health is something I compiled that has the local therapy services, but also has them broken down by people who do EMDR, people who work with kids and things like that, kind of what their availability is as well. So I'll leave this up here just for a minute for anybody who might want to snag those QR codes and have access to those. Okay, lots of sources, lots of research on this. And that's the end. I will share my email real quick for anybody who wants those CSSRS business wallet cards. My email is Brittany, Brittany at shawamigancounseling.com. If anybody has questions or follow-up thoughts or questions about what this might look like in specific settings, schools or as a first responder or maybe in a clinic setting, please just email me and I would be happy to chat about that. All right.